Hi, everyone. Good afternoon. Today, we're joined by Dr. Brandon Webb, an infectious disease physician here at Intermountain Healthcare, to give a COVID-19 update for the state of Utah. We're going to go over case trends first and what's been happening since the last time we've spoken. It's been around a week since it's happened. Dr. Webb, thank you so much for joining us, though. It's nice to see you.
My pleasure.
So the case counts for today were just released. So the numbers I will be telling everyone are from today. The daily case counts for today are 873. We had a reported 4 deaths today, with 1 being reported prior to July 1st. Our hospitalizations currently stand at 295, and our 7-day average for percent positives is 13.4. Yesterday, we also added 495 of the Delta variants, bringing Utah's total to 2,699. That will have increased from today. I just don't have that specific number for you. Let's start there. I would love to have an overview of how it's feeling in the hospitals. It seems like we're almost back to where we were last summer, which is a scary thought. So kind of explain to us how our caregivers are feeling and what it feels like working in units right now.
Yeah, thanks, Amanda. We are in a very similar place as we were last summer. Unfortunately, at all of the major hospitals across Utah where COVID admissions tend to cluster first, we're seeing ICU units that are filled or filling very quickly with COVID only, which is a big change from what we've had over the last few months, where we've been able to care for patients of many different types of conditions. In several of the Intermountain hospitals, we're already starting to move into those similar surge plan phases for ICU care, because what we're seeing right now is reflective of the community transmission in the last 2 weeks, 2 to 3 weeks really, for admissions. And so we expect that the hospitalizations that we're seeing now will unfortunately just continue to increase.
And what type of demographics are we seeing in our hospitals right now? Or is it younger, older, vaccinated, unvaccinated? Can you give us a little brief overview of that as well?
Yeah, absolutely. The primarily older high-risk population of the winter and last fall has really been replaced by a population that is largely unvaccinated and younger. We're seeing patients in their 30s and 40s, many of whom have obesity, for example, or other medical conditions, who are not vaccinated. And that does comprise a large number of the admissions. We are seeing some very high-risk individuals, especially patients who have compromised immune systems, who didn't respond well to the vaccine, but that does comprise a smaller fraction of our hospital admissions.
And what about our impact on our caregivers? You mentioned that our ICUs are more full. Is the atmosphere different than it was a few months ago? How are people feeling overall around what's happening?
Yeah, unfortunately, I just talked to an ICU physician yesterday who was expressing exhaustion already. The pandemic has taken its toll emotionally and psychologically on all of us. And the frontline caregivers, especially the nurses and physicians who bore the brunt of the hospital burden all throughout this winter, are really, I think, struggling with the reality that we're moving into another phase where we're going to be full again.
And we've mentioned this time and time again, it seems like most of the hospitalizations are with those who are unvaccinated. I'd just like to talk about vaccination as a whole right now. How is the state of Utah doing comparatively to other places? And do you have any general messages for those who are still unvaccinated at this point?
Yeah, so compared to the rest of the country, Utah had a fairly brisk uptake early on, and like everywhere else in the country over the last month, vaccination rates have really dropped considerably, and that's true in Utah as well. We've sort of plateaued out. Currently, approximately 51% of Utahns are fully vaccinated. And as you know, that falls well below the target numbers that will give us protection from these increased rates of transmission with the Delta variant, which absolutely has become dominant. We expect that the Delta variant right now accounts for probably 85% of all transmission. And the other variants, including the beta and gamma variants, round out the rest of the transmission.
A question we were just asked is around elective surgeries. Is Intermountain having any plans to postpone any surgeries coming up, or is there any impacts directly on what this surge is going to do for a hospital system?
Yeah, so right now we're in a phase where we're monitoring the access to healthcare across the board, both to surgical patients and to patients who require healthcare for a variety of different conditions. And I think it's important to reiterate that access to good healthcare, whether it's for COVID or for other conditions, is critical. It's really important for our community. And when one single disease like COVID dominates, it displaces the ability for the healthcare systems to care for patients who need it, who have non-COVID conditions. And surgery is one of those areas where we're watching the ability of our hospitals to care for all patients very carefully, looking at our ICU numbers and taking all of that into account. As of right now, Intermountain is not delaying or postponing any surgical cases, but we are watching the overall picture very carefully.
I want to talk about breakthrough cases. We've seen a lot of public figures or well-known figures come out and say that they've gotten COVID after getting the vaccine, and you hear about these people because they're well-known. I want to talk about what that means for people who are vaccinated. What is the statistical probability of you getting COVID after getting the vaccine? And what does that mean with people who are vaccinated versus unvaccinated, this like never-ending cycle almost?
Yeah. Breakthrough cases are really a direct representation of the effectiveness of the vaccine. So when you read about vaccine effectiveness, that's exactly what we're measuring is in how many patients who were fully vaccinated did breakthrough cases take place. And we know that no vaccines are perfect, so the vaccine effectiveness is never 100%. What's different about the COVID vaccines compared to vaccines like influenza and others that we're maybe more familiar with is that the vaccine effectiveness rates, even against the variants of concern, have been very, very good for symptomatic disease and especially for preventing severe disease to the level that hospitalization is required. And so we do expect to see breakthrough cases. We are seeing more breakthrough cases with the advent of the Delta variant, but overall our vaccine effectiveness numbers are still extremely good. We hear about the breakthrough cases, but what we don't hear about is the denominator, the larger number of people overall who've been vaccinated and who are protected against COVID. And I think that it's worth re-emphasizing that these vaccines are very effective and remain effective against the things that matter most, which are decreasing community transmission, which the vaccines are very effective at preventing, and preventing severe disease that requires hospitalization.
We just got a question around a study that is coming out right now that's suggesting that Johnson & Johnson's vaccine might not be as effective against the Delta variant compared to the other two vaccines on the market. More than 132,000 Utahns have received that shot. For greater protection, should these individuals receive the other vaccines? Do we have any suggestions or data on that specific piece?
Yeah. It's a good question. We're monitoring all of that data and those scientific studies as they're released. And at this point, it is true that the adenovirus vector vaccines, including AstraZeneca and Johnson & Johnson, tend to have less effectiveness at preventing infection due to the Delta variant than the mRNA vaccines. Strikingly though, those vaccines are still very effective at preventing severe disease. So Utahns who have received the Johnson & Johnson vaccine can be reassured that while they may not be as well protected against the Delta variant, if they do have a breakthrough case, the symptoms are much more likely to be mild and far less likely to result in hospitalization. We're watching this very carefully. The CDC recently was advised or briefed by an advisory panel on mix and match strategies. And we are now seeing a lot more data on the effectiveness of mix and match strategies. And so we're going to be watching those decisions very carefully and may see some policy changes with respect to whether patients who've had one type of vaccine should then have a second vaccine. But right now, that's not recommended by the CDC. And the most important protection, the protection against severe disease, is very reassuring with Johnson & Johnson.
Another question we just received is some countries like Singapore are not really counting coronavirus cases anymore, and they're treating it more like the flu. Is that a good strategy for Utah, or would it be a bad idea? What are your thoughts on that?
Yeah, flying blind is never a good strategy in general. Good policy is almost always based on good data. And so the more good data we have on community transmission and other metrics, the better we'll be able to make decisions from the policy standpoint and from a public health standpoint and from a healthcare standpoint. So from, as far as Utah goes here, we enjoy resources and a robust public health environment with the Department of Public Health working closely with others in the state. And I think for us, it makes much more sense to have as much visibility, as much data as we can.
Today, also during the briefing that the Utah Department of Health put out, they are asking everyone to go get vaccinated. And we keep hearing this, go get vaccinated. It works, it's safe. Millions of people have gotten the vaccine so far. And it seems like the needle isn't still moving fast enough. What's it going to take to get this in check with our case counts and hospitalizations rising?
Yeah. Amanda, the reality is that the pandemic is not over. This is a terrible disease that still affects people's lives and livelihoods. It's affecting more and more Utahns every day. The consequences are not limited to health only. They impact our society and community in many, many ways. With increasing case counts, we are now again in a position where we're going to have to face the possibility that social restrictions in different venues may be necessary to control the disease, to decrease hospitalizations and decrease unnecessary death. And all of that can be prevented through vaccination. More than 330 million doses of vaccines have been given in the United States in what amounts to the most wide-reaching and most thorough vaccine safety surveillance program in history. And all of that has given us more transparency and more insight into both the effectiveness and the safety of these vaccines than we've ever had with vaccine products before. And with that, a tremendous amount of visibility, we can say confidently as healthcare professionals and providers that these vaccines are safe, that they are well tolerated, and that they are remarkably effective. And that for everyone who's been impacted by this ongoing pandemic, vaccines remain the single most important thing that we can do to decrease community transmission and get back to normal.
And speaking of that, getting back to normal too, school's starting again, which is crazy, in about a month and a half, depending on who you are. And a lot of parents are worried that their children who are under the age of 12, who cannot get vaccinated yet, could potentially be at risk for contracting COVID-19. Do you have any suggestions for those people as the school year starts to get closer?
Yeah, we're facing a situation now where it's going to be very important for the public to work closely with our education leaders on policies that protect school-age children, especially those who've not been able to be vaccinated. Fortunately, the transmission rates in the youngest age groups are lower, but it's still important that the school age populations remain protected and that we protect teachers and others in the education systems. And so we look forward to very close collaboration and good dialogue with the leaders of education across the state to identify the strategies that are going to be effective this fall, which include a number of things, including testing, surveillance, contact tracing. Masks, although not mandatory, we know that they work. They were the tool that allowed Utah schools to stay open all last year. And so parents of children who are concerned have a number of different tools at their disposal. And we look forward to continuing to work with education leaders to make sure all of those layers are brought to bear this school year.
A follow-up question from one earlier. A difference between this summer and last summer was there was a lot of broad public support for healthcare workers and first responders last summer. It seems like people are now moving on and acting like this pandemic is completely over. How are our healthcare workers feeling about that? How are you feeling about that?
Yeah, I'll be honest, Amanda. I think that there's a sentiment amongst the healthcare community that we're worried about being abandoned. We sure appreciated all the support last summer, fall, and winter. We really appreciated sort of the outpouring from the community and, more importantly, the engagement from the community. People making personal sacrifices to decrease transmission. There is certainly a sentiment among healthcare workers now that that the community is sort of so tired of this that they're ready to abandon the precautions that worked over the winter, which I certainly understand, but we're still seeing a significant burden, and we're having to take care of many patients, many more patients now than in the last few weeks, who are critically ill and some who are dying of COVID. And it's hard.
Yep. I mean, I can't imagine. So I hope things move in the correct direction for everyone who's still working on the front lines for this. Another question we received too was around the vaccine and how long immunity can last. So I know the clinical trials started last October, November, roughly, and there was reports that they were lasting around 6 to 8 months so far. Can you kind of explain what that means as far as how long the vaccines are lasting, since it hasn't even been a year since the trial started?
Yeah. And that's the key point, is that over time, we will have more insight into how long the vaccines remain effective and whether there is a drop-off in effectiveness. There have been a number of studies so far that have measured what we can measure: antibody levels of T cells and B cells, including memory B cells, that allow us, once immune to a disease, to mount a response if we're exposed to that disease again. And so far, all of the data for the vaccines has been favorable. It suggests that the response to the vaccines does last months, and we have data up to 8 months or so at this point, and are rapidly acquiring data from those early clinical trials on people who were vaccinated up to 12 months ago. And I think that we're going to learn more and more as we have some more time under our belt. But so far, the results have been encouraging that the immunity from vaccination does last, and those who are vaccinated first are likely still protected. And on that same point, Amanda, do you mind if we talk about the immunity that comes from natural infection?
I was just going to ask you that question. Yes, I'd love to understand the difference between that as well, and what you'd recommend for them as well.
Yeah, it's a really important question. So far in Utah, about 440,000 individuals have been diagnosed with COVID-19. And we recognize that that probably represents to some degree a tip of the iceberg effect, where other individuals may not have been laboratory diagnosed with COVID-19. That the question about whether natural infection results in long-lasting immunity has been the subject of a lot of research recently. And so now we do have a much better idea of how long immunity lasts after natural infection. We knew already from experience with other coronaviruses that the immunity after natural infection lasts about 1 season. For healthy individuals who are exposed to a cold virus due to coronavirus, generally that immunity lasts about 9 months or 1 cold and flu season. And so far, the data for SARS-CoV-2 is very similar. It suggests that if you are healthy and had symptomatic COVID, the immunity that you generate from that probably lasts for most healthy individuals about 1 season, 8 months or 9 months. The problem is that that varies widely based on individuals' health, age, chronic medical conditions, and especially the health of the immune system. And there are a lot of individuals in the community whose natural immunity lasts far shorter than that. The other thing that's really important to understand is that natural immunity is effective against that strain or similar strains. So that's a concept known as cross-neutralization. And we know that these recent studies that have suggested that immunity after natural infection is long-lasting are looking at immunity to that strain or similar strains. We know, unfortunately, that these new variants of concern are different enough. They have mutations that make them different enough that the cross-neutralization from previous strains can be very poor. I'll give you a couple of examples. In Brazil and in South Africa and in India, during the first wave with the first strains, the 614 strain or the alpha strain, they had areas in those countries where up to 75% of people in communities had been infected. So their herd immunity, if you will, was up to 75%. And when the new variants, Gamma and Beta and Delta, entered those same communities, the cross-neutralization was poor enough that we had significant second wave spikes with secondary infections or repeat infections of upwards of 60%. And we're now seeing the Delta variant in Utah, and we expect that, like we've seen in other parts of the world, cross-neutralization or good immunity from one strain to the Delta strain is unlikely. What you do get from vaccination, even if you've been infected in the past, is a much better cross-neutralization. So there's multiple studies now that suggest that individuals who've had COVID and are then vaccinated generate a very strong immune response with antibody levels up to 40 times higher and have much better protection against all of the variants of concern. And that's the single most important reason to be vaccinated, even if you've already had COVID-19.
A follow-up question on that as well. Should Utahns, including those who are fully vaccinated, return to wearing masks in indoor settings to stop the spread of the Delta variant? And what about outdoors as well? What are your thoughts on that?
So going back to the basics that we've talked about all along throughout the pandemic, individuals who are at high risk in settings with poor ventilation, where distancing is not possible, are at higher risk of acquiring COVID, and individuals who are not vaccinated are at higher risk of asymptomatically transmitting it to others. And so in those settings, especially in indoor settings where there are more dense crowds and social distancing is not possible, transmission is far more likely. And unfortunately, with 800 cases per day, we're in a position now at the state of Utah where we need to start re-implementing precautions to decrease community transmission, because we are seeing unnecessary hospitalizations, and preventable deaths.
Another question that we received, and there was reports about this from out of Alabama recently, but have doctors told you of patients in your ICU expressing regret for not getting vaccinated after landing in the hospital?
Because of privacy reasons, I'm not going to share any individual examples, but that sentiment is something that we're hearing in the healthcare setting. We are hearing from individuals who thought they were safe and weren't, and ended up getting very severe disease and were hospitalized, and it affected them significantly and their loved ones. Some regret there. I think, Amanda, if I could, it's important, I think, for those who consider themselves relatively low risk to understand that even in the 25 to 44-year-old age group, hospitalization due to COVID is almost 3%, which is somewhere between 10 and 40 times higher than influenza. And even if patients in that age group don't pass away from COVID, hospitalization itself and the sequelae, the consequences, are severe. If you're hospitalized due to COVID, your risk of having long COVID or persistent symptoms is upwards of 30%. And the costs associated have been devastating. Right now, about 1 in 6 families have medical debt. And the cost of even an average COVID admission is almost $25,000. Those are reasons for individuals who are considering the risk benefit to take that into account when making the decision about being vaccinated.
On that same lines too, you mentioned the 30% for long COVID. Is that number the same for those who are vaccinated? Is there any study between the difference of someone who can contract long COVID vaccinated versus unvaccinated?
We don't know that yet. We do know that the severity of COVID directly correlates with how likely it is that you get long COVID symptoms. And we know that vaccines decrease the severity tremendously. So we expect that patients who have been vaccinated will have lower chance of getting COVID, lower likelihood of having severe COVID, and very likely less risk for having long COVID symptoms.
Another question for you too around vaccines. If you're fully vaccinated and happen to have a breakthrough case and contract COVID-19, so you've been 2 weeks past that second dose, how long should you quarantine for? And this is probably a general question. Have the quarantine guidelines changed at all in the last year for contracting COVID?
They haven't. If you've been diagnosed with COVID, or if you are in the community, whether you've been vaccinated or not, and you develop symptoms that are consistent with COVID, number one, we do encourage you to be tested, first of all, and to avoid contact with others while you're waiting for your diagnosis. Isolation is still 10 days for individuals who have non-severe disease and whose immune systems work. And that 10 days is still a very important thing for preventing transmission in the community.
Another question for you. We have lots of questions today. Is there a metric that we can use as a healthcare system or a state in general that will help us advise social restrictions potentially being put back into place? Is there like a certain threshold that we look to with data on when that could become a thing?
One thing that the executive branch and the legislature and the Utah Department of Health have done well during the pandemic is to use data to help guide policy making. We've had the levels of transmission, and if you look across the board at the state map, most of our communities are now in high levels of transmission. Those numbers do inform policy decisions, and especially with respect to specific situations where reinstituting precautions are necessary. And I know that those discussions are being had right now at the level of the Department of Health, in the Department of Education, with businesses and community leaders, with religious groups. With the new increase in cases, discussions about implementing social restrictions and other precautions are being had as we speak.
Last question for you. Do we have any sort of updates around those 12 and under who could potentially receive the vaccine on a timeline for that?
The last I heard was that we were expecting authorization for that youngest group from 12 down to as young as 3 months, based on advisory panels that are advising the CDC sometime in September. And those advisory panels are currently ongoing, as are advisory panels that are advising the CDC on mix and match policies and boosters, especially for those who are immunocompromised. So we expect that we will have additional guidance as we go along. You know, Amanda, before we wrap up, can I put in a plug for early testing and for monoclonal antibody therapy as well?
Yes, I was going to ask if you had any wrap-up thoughts before we took off for the day.
Sure. You know, number one wrap-up thought is let's continue to encourage our community to get vaccinated. It simply is the most effective thing we can do. But secondly, I would strongly encourage members of the community, if you do get sick and your symptoms are compatible with COVID-19, to get tested. We have a lot of testing opportunities all over the state. And getting tested early in your symptom course is important, not only for preventing transmission, but for those who are at higher risk. There are treatments available. Monoclonal antibody treatments are available in all corners of the state, and for higher risk individuals are effective at preventing hospitalization.
And on that note as well, if anyone has not received the vaccine and they're interested and would like to go get it, we have a great resource. It's intermountainhealthcare.org/COVID vaccine. You can find out where there are pharmacies or different clinics happening around the state. Dr. Webb, thank you so much for joining us again today. I really appreciate your time, and we will talk with you next time.